I'm going to get started with just few brief announcements. I know the main event is here now, and I appreciate all of your patience. As you know, UCCS-IASP was announced on April 30th. It's an interdisciplinary academic studies program. And there have been two events in June where we had a 5-hour event one time, and then also followed by Professor Melanie Mitchell coming from Santa Fe Institute. Also, there was a third event in September. You might have attended that also, which was on new media. Catherine Hamilton from MIT, kind of MIT-related work was here presenting ARK, a novel virtual reality approach. This is the fourth event we have. I'm very happy to host Dr. Joshi. Karen, please go ahead and talk about it. Only one more thing. The next event is November 12th. So please mark your calendars. We'll send you more messages on that. Karen, take it away.
Thank you, Dr. Semwal. Good morning, everybody. My name is Dr. Karen deVries. I'm an instructor in the philosophy department. I'm also on faculty with the Honors program, and I work closely with the IASP. It is my pleasure to introduce Dr. Gagan Joshi this morning. He is the director of the Autism Spectrum Disorder Program and the medical director of the Bressler program at the Massachusetts General Hospital. He's an associate professor of psychiatry at Harvard Medical School. He trained in general psychiatry at the Hospital of the University of Pennsylvania and subsequently completed his fellowship training in child and adolescent psychiatry at the Massachusetts General Hospital at Harvard Medical School. He received training in cognitive behavioral therapy at the Beck Institute for Cognitive Therapy and trained in psychodynamic psychotherapy at the Philadelphia Psychoanalytic Institute and Society. Dr. Joshi has been the recipient of the prestigious Ethel DuPont Warren Fellowship and the Norma Fine Fellowship Awards through the Department of Psychiatry at Harvard Medical School. He's also the recipient of the Collegium International Neuropsychopharmacologicum Congress Young Investigators Award and the American Academy of Child and Adolescent Psychiatry Pilot Research Award. Dr. Joshi's clinical and research interest is in ASD, autism spectrum disorder, in the context of psychopathology in intellectually capable populations. In addition to providing psychiatric care to individuals with ASD through the Bressler Clinic, Dr. Joshi is facilitating research that examines the clinical and neural underpinnings and pharmacoimaging treatments of high-functioning ASD and associated psychopathologies. It is my pleasure to introduce you to Dr. Gagan Joshi.
Thank you, Karen. Thank you. I must say to my, I would call my Mama Ji. I know he said Dr. Gagan Joshi, and that was so strange to even hear. I'm gonna get to my slides and then just bear with me because this is gonna be a roller coaster journey. Should I share the screen right now? I am on the meeting. Share the screen, go down. Too many screens open up here. I'm sorry about that. Oh, here we go. We got it. I'm gonna share it. And then go to the space where the screen is. Okay. So thank you all for inviting me. Should I take over now, Karen?
Yes, take it away.
Wonderful, wonderful. So we'll be talking about clinical and neural correlates of autism and associated psychopathology. We all talk about things what we say. And I am the medical director of the Bressler program. And through that, I treat individuals of all ages with autism spectrum disorder. And by nature of my program, these individuals are all intellectually capable people. So before I talk about the neural correlates, I would like to introduce you to the population I treat. And just bear with me, this is gonna be a little bit of a tedious journey. Now I gotta go here. Wonderful. So let me start here. A long time ago, when I started seeing folks with autism spectrum disorder, keep in mind, no two autism people are the same. And even in autism population, there's a huge divide between the intellectually capable autism and the intellectually impaired autism. All through this presentation, I'm going to be talking about intellectually capable autism as high functioning autism, then the other set of autism is intellectually impaired autism. Let me start with the core feature of autism. And without this feature, you will not see an autism who has nonverbal communication intact. Now, what is nonverbal communication? Anything what I'm speaking right now is verbal. Everything else, my tone of voice, my emotional expressions on the face, my body language, my gestures, they're all nonverbal. What is important about nonverbal is that emotions, feelings, they travel through nonverbal pathways. Words by themselves are oftentimes not adequate to express emotions. A good example is babies, when they're born, they don't have language, but my golly, they do not fail to communicate what they're feeling because they use all nonverbal ways. Their tone of voice, the way they cry, the way they have this body language. You clearly know when the baby is in distress. You clearly know when the baby is happy, even though they do not have the language. So emotions travel through nonverbal pathways, and in emotions, in the autism population, this nonverbal communication is impaired. Now, I want to highlight here, and let me take a moment to talk about this little study we did on the side of our other studies, is to see that the nonverbal has two levels to it. If we can define it as a high intensity nonverbal, that means when you're smiling, and it could be a laughter, when you are panicking, when you are just upset. So if you are crying, tears flowing down, if you are laughing loud, if you are panicking, like, oh my God, it's the end of the world, or if you're angry, all these are very intense emotions. So let's call them high intensity emotions in the nonverbal. Then there are these low intensity emotions. When you're just smiling, when you're just a little bit of a irritable look you have, when you are a little bit of a sad mood, when you're just feeling a tad antsy. Let's call that low intensity cues. We divided these cues and we looked at the high functioning autism population versus the low, but we don't have data on the low one here. But what we know in the low functioning population, they cannot read any cues, either it's high intensity or low intensity. But in the high functioning population, when we've looked at the errors they were making in reading a tone of voices of low intensity and high intensity, the low intensity is orange, the high intensity errors are in blue, and also reading facial expressions, the high intensity and the low intensity, we found that they were making way less errors in reading the high intensity nonverbals, the tone of voice or the facial expressions, but they were making many errors in reading low intensity nonverbal communication. The reason I highlight this is because when the babies are born, they may have the capacity to read nonverbals, but they are not born with that competence right away. All the babies across the globe, in any culture you take, whenever innately, I think it's in our DNA, whenever we see the babies, what do? We exaggerate our nonverbals. Why do we exaggerate them? Because babies cannot read subtle nonverbals. Any baby, autism or no autism. Actually, I would argue that everybody is born autistic. The autistic traits are present from the day one of their lives, but I'll talk about that in a minute. So I wanted to highlight with this slide one important fact, that in high functioning population, they are often able to read the high intensity nonverbals, but have difficulty reading the low intensity nonverbal. Having said that, here we go. Now, I'm going to go through and paint a picture of what is a high functioning autism spectrum disorder person. A high functioning autism disorder person oftentimes makes good eye contact. So, one of the whole hallmarks of autism, they don't make eye contact and they're looking at the ceiling while they're talking to you. Not true with the high functioning population. They make good eye contact, but they don't use the eye contact to read nonverbal communication. So they will be looking at you. They will be listening to your words, but they are not reading the nonverbal communication, what you're trying to send them. So if there is a sarcasm, if there is a joke or a pun, they don't get, they take that very literally. At the same time, they themselves, they are verbally intact. They have actually, they can be extremely verbose because they do not use nonverbal communication to communicate with others. Everything they translate that into language. So they are extremely detailed. They don't leave anything to be read between the lines. They don't use their eyes or their facial expressions to communicate non-verbally what they're talking about. So they are extremely verbal. But here's the trick about the verbal communication they have. They are very verbal, mostly about intellectual things, but not verbal in expressing emotions. So their verbal expressions of emotion is often anemic and depleted. They have difficulty processing emotions. So what usually happens first, they don't even have the salience or register anything emotional in the room. Oftentimes, if you show them a room, they will be more drawn, innately drawn, which we call as salience, to things which are non-emotional, non-human, and not drawn to emotions. If they are even drawn to emotions, hello, I'm okay? Hi, is everybody able to hear me? I heard somebody talking. Okay, fine. So they are not drawn to it. When they are drawn to emotions, they oftentimes are not able to read emotional states of people unless they are verbalized. So oftentimes these folks will often ask others, what are you thinking? Or they will coax them to verbalize what emotions they're going through because they cannot read it. What this leads to in the high functioning population, that they are able to read intense emotions. So if somebody is giving a subtle emotional hint that this is not okay, or they don't want to hear something, they are totally socially, emotionally blind to read that. Till the point that person shows an intense emotion because it has been, building up, then they're often surprised. Oh, I don't know why that person got angry. So this emotional processing is poor. Their social interpersonal processing is often poor. They don't understand the context that certain behaviors are acceptable in certain situations. They don't understand people's motivations. They have difficulty socially sharing or being socially flexible. One good example I'll give you, I had this young man who was a great trumpet player, and he wanted to date this girl, and dating has been a challenge in this population. So I told him, hey, look, after the show, why don't you offer this girl that you will drive her? You have a car, she takes a train to the city, you will drive and drop her there. Guess what this man says to me? Oh, no, I can't do that. Because right after the show, I always sit my buddy to have a bottle of beer at the bar, which we have been traditionally doing for years. I cannot change the routine. So that social flexibility is not in them. What is the most challenging part for psychiatrists is in this population that they have very limited understanding of abstract things. They're very black and white. They often are very concrete in their thinking. They just rely on what you say, don't read between the lines. And anything which is subjective, in which they have to introspect with the psychological mindedness, they lack that. There are two parts of the brain internally. Let's say the left side of the brain is the intellectual insight. The right side is the emotional. They have an extremely good intellectual insight about intellectual aspects, about our arguments and logical thinking, but they have a very poor insight or their vision, internal vision towards emotional aspect of understanding. So they have very poor understanding of their feelings, emotions, their antecedents, and then expressing them. In general, in life, everything is all or none for these people. Either they are more than 200% interested or not interested at all. And what we call that as executive control, that means learning how to put brakes on your feelings. They do not have that control, and oftentimes are too delayed in developing a reasonable control over their motivations, interests, and intentions. Along with that, one of the most debilitating part of this population is that they're extremely rigid in their routines, rigid in their opinions, rigid in their value system. They have difficulty transitioning from one activity to the other. They're not very spontaneous people. Their spontaneity is not part of them. And that leaves them oftentimes stuck where they are and have a challenging time changing their behaviors. One of the most interesting features in autism, which was not part of the core features of autism in the DSM, and that's why we don't follow DSM in general, we follow the traits, not the disorders here, is the social sensory dysregulation. Their sensory system is atypical. They are often hypersensitive to certain sounds, atypically seek sounds which typical folks don't like it. They have these sensory issues with light touch, but they like the pressure. They do not like certain smells, or they like smells which oftentimes typicals may think pungent. Body odors, sometimes they are either drawn to it or can't stand it. All this plays out in their social relationships because sensory system is, as I said, is the modality through which emotions travel. What a hug can do, no amount of writing can do it. What one emotionally laden statement can do in your tone of voice, you may write pages, you may not be expressive. So sensory dysregulation really does a disservice in this population in terms of emotional communication. Okay, now let's see what the traits are. I mean, we are doctors, we have a diagnosis, there is a threshold. If these traits are in numbers or in severity are good enough to cause an impairment, we call that autism. But autism is not a dichotomous diagnosis. If I give a screener to a general population, which people have done, and they have found that the autistic traits are not on the screen like 0, no autistic traits, or all autistic. No, it's a spectrum starting from very minimal autistic traits to severe autistic traits. So nobody is spared of autistic trait, but that doesn't mean they suffer from a disorder. They only suffer from disorder if these traits are to a level of quantity and severity extend to a point that they cause impairment. That's when it's called autism. My pet example during this time of the year in New England is the fall season. Now, let me tell you that I was telling you about how every child, every baby is born autistic. Actually, part of the maturing process in human beings is to shed the autistic traits as you grow. And that's what we call as maturing. Babies are born as rigid, unempathic. They don't have theory of mind. They don't read subtle nonverbal well. All these things, they are inflexible. So all these things, as babies grow and mature, they develop flexibility. They develop the capacity to read subtle nonverbals. They develop capacity to understand other person's point of view. All these are as if in the fall season, as the fall comes, when the trees are shedding the leaves are like autistic traits. As these kids grow, they shed these leaves. But there are very few trees out there which have shed all the leaves. There are some trees which have all the leaves on it, the pines, so they are like laden with autistic traits. And then there are trees which have partially shed the trees. Most of the people belong to that they have shed a lot of trees, but there's still some leaves hanging in as autistic traits in their life. So I want to give you this perspective that these traits are across the spectrum, and you probably, and all of us have friends and folks around us who have some more traits than others, but that only makes a disorder if you have an impairment. Okay. Now, taking these traits, calling them a disorder, looking at the prevalence. And I want to highlight the prevalence because the prevalence in the general population shows what will come to our clinics or what the doctors are treating and what kind of autism is highly prevalent. So over the last decade, the prevalence of autism in the United States, as CDC tells us, has more than doubled. It used to be 7 in 1,000 to begin in 2000, and every consecutive survey done every other year has led to the middle of the 2014, 2016 to up to 18 or 19 people in 1,000. So the rates have really more than doubled. Now let's see what has increased the rates here. The classic autism, which has oftentimes it's too severe, not socially curious, is oftentimes intellectually impaired with some savant skill sets like the Rain Man in the movie Rain Man. And I give this example, but I think I've become an old generation. A lot of young folks have seen this movie. If you haven't, go watch the movie, because autism is a very non-verbal disorder. Till you don't see it, you don't get a sense what autism is like. This is a great movie to watch to see an intellectually splintered savant, severely autistic person. The rates of that particular autism, they have not shifted. They have stayed stable over the years from 4 to 5% or 6%. What has contributed to this rise are the intellectually capable autism, all that autism which is intellectually at par or superior to the general population, going to the regular public schools, to colleges, and working in industries, most of them in the California region or in the MIT we have around here, doing a very superior intellectual work, but suffering socially. This is, now this you will relate to Big Bang Theory. The characters in that Big Bang Theory are all in the spectrum, starting from Sheldon to Rajesh. So all of them fall in this spectrum, and this is the autism which we are recognizing now. Not that the incidence of autism increased. There seems to be a huge backlog of high functioning autism, which was never recognized. If you ask me as a clinician, because I treat people of all ages, more often than not, the parents will bring their child for the diagnosis of autism, and then they get caught in the net because one of the parents often has autism because it's a highly familial disorder, and the apple never falls too far from the tree. So never have a control from the family because they probably also have autistic traits. So that will really mess up your research. Now look at the disability burden. What kind of population we treat? So I'm leading you to the point to say that the population we treat are high functioning, but what age range is the population of our interest in our research? Autism spectrum disorder has changed its name over time. It used to be called the pervasive developmental disorder in DSM-4. In that, we looked at the severity of impairment of various disorders in psychiatry. This is lifetime, starting from the age 0. Some disorders becomes most severe at a certain stage of lifespan, and then they ease out over the years. So across the lifespan, if you look at for autism spectrum disorder, it's a light orange here. You see it starts showing impairment by the age of 4 to 6 to 8. What happens at this transition age, the high functioning autism kid, you know, if I show you two babies, a 4-year-old, and I ask you, who is a math genius here? You won't be able to tell till they don't do the math. Same is true with autism. Only when the social demands rise to sort of see your skills to match the demand, when they fail to do so, that's when the social impairment of autism starts showing up. It never shows up at 3 years or 4 years. It starts showing up when the kids from preschool start going to school and their social skills start increasing. Their mode of communication, if you are parents and if you had young children and teenagers, you clearly know that the teenagers communicate more non-verbally than verbally. They hardly say yes, no, maybe. And they use non-verbal, the subtle ones, just to let you know that back off, don't want to talk about this, rolling their eyes, making a face. So teenagers usually use subtle non-verbal communication. So their style of communication shifts heavily to subtle forms. And what happens in subtle is oftentimes it's a negative non-verbal which they use. Now, an autistic kid who relied heavily on verbal communication, by the time they hit the teenage years, which is this age range here, they are socially so impaired to read the social cues, those subtle non-verbals. Along with that, these are the times in you're in teenage, your prowess is determined by your social competence more than your intellectual competence. So these kids who could be intellectually very capable, when they hit this age range, they are totally socially so blind and impaired that this is where the autism severity is the worst in the lifespan. And this is the population which often ends in our clinic. If you notice here, more than 50% of people who come to our clinic are at the age range between 8 and 17 years. This is the very population is the target of my clinical work and my research. And my research is all born out from this population. And I'm very grateful to them to have faith in me and participate in research at our lab at MGH. Okay, who are these people? They are all among us. Actually, all of you, if you can close your eyes and go back to your childhood, from your early years till your college days, you will see that there were people around us who were autistic. Here is a pizza guy who doesn't like transition, never changed a job in 20 years, had been sort of biking pizza in the city, no matter it's rains or it's winter or it's summer. His autism has never let him progress. Here is the young lady who is a savant. She won amazing, competitions across the globe for playing piano. And actually, she has even run one of the symphony, her own creation was played in some Canadian symphony. But that particular girl has extreme emotional lability. She does not understand emotions well. When that happens, she gets very labile and she screams like a 4-year-old. Here is a culinary genius who is a great chef, but in autism, because the processing speed is slow, he cannot be too quick to make the dishes in a restaurant or make it what others want. He just does what he wants. Still remains a genius. And notice one thing, he has long hair because they have sensory issues. They don't like to have haircuts. Their clothing are oftentimes very loose. And has a very strange kind of mustache which he likes because he is a Dolly fan too. Here is a software engineer, a genius in her own work, likes to work in isolation. COVID has really been a blessing for her because she can do all her work from home, but cannot date anyone and struggles to have a relationship. And then here is another autism folk who was never diagnosed early. I diagnosed him at the age of 21. Extremely smart man, cannot tolerate his emotion, and has got into drug addiction. So these are the kind of folks I treat. Okay, so what did we find with this population? In my early studies we had a collaboration with MIT, and we had this kind of animated car or what do you call that, Volkswagen Beetle car as a driving to test their driving abilities. And we had a huge screen as a road, and we were trying to see, why do autism people oftentimes refuse to drive? And my grandiose hypothesis to begin with was, maybe their coordination is not good, that's why they don't want to drive. But it turned out to be very different. These were young people with driver's license. And what we found, that when we had the eye trackers and autonomic sensors on them, they oftentimes were looking not at the road, but higher than the road. So you can imagine that they are not very sort of really looking at the road, and they're prone to accident. They were scanning the road, not just the road, but even the side pathways and the trees. So they were scanning a way large area. And whenever there was a break or something, they would start looking at the median rather than looking in the front. So it seemed to me that they had a very atypical way of scanning the road. And oftentimes when we had this kind of a test to see that we would call them on a mobile and see how they react, their level of anxiety would be so high that they often wobble on the road while trying to respond to the mobile phone. And guess what? These people had driver's license. We have recently completed another set of study based on this to see what kind of errors do they make. And once we have the results, we'll share it with everyone. Now, talking about psychiatric condition, I just want to tell you that when you look at the general population and see what rates of emotional and behavioral difficulties people have, usually 15% of the population in their lifetime in this country had some emotional behavioral difficulty as a child. In autism, and this is high functioning autism, by the way, because they are mostly in the society and not in the specialized places, it is more than 2/3. 83% of the population have a history of childhood emotional behavioral difficulties for which they did seek some help. So emotional problems are at an extremely higher rate with high functioning autism. And we have shown with that studies, if you compare the emotional difficulties between low functioning and high functioning, the high functioning autism has more depression, more anxiety, and more ADHD, attention problem, than the Rain Man kind of severely autistic population. And here is the thing. If you ask someone for a severely impaired autism, who suffers with social impairment? Actually, the social deficits in severely impaired population, it's the family who suffers from that social deficit, because they want to relate to the person, but the autistic person themselves have no interest in engaging with them. So they don't carry the impairment affecting their emotions because they don't want it. In the high functioning population, it is that population who wants to socialize but don't have the skills, and they themselves suffer from the deficits of socialization because whenever they try to engage in this social dance and engage socially, lacking the skills often leads them to be rejected, heartbroken, and emotionally dysregulated. So in high functioning, it is the patient themselves who suffer from the impairments related to their social deficits. Okay, so we talked about the rates of autism in the general populations are around 1.8%. 5 times higher rates of autism are found in the emotionally disturbed population, which comes to our clinics. So we have a greater burden of autism in our clinics than in the general population. I will not go in details with this because this may be relevant for our presentation today. Just want to highlight one fact that the population with autism, which is in orange here, and the other population which comes to our clinic with emotional behavioral difficulties is in blue. The rates of and the burden of all the psychopathologies are at the same rate in autism as it is without autism, except for anxiety disorders. Autism folks have tremendous anxiety. And I'm highlighting this that not only that the autism itself is a heterogeneous disorder, keep in mind, their psychopathologies are also heterogeneous. If you put the psychiatric disabilities they have along with the autism and put them in together, each of them is so unique. Then when you do research, and if you don't control for the emotional behavioral difficulties, because each emotional behavioral difficulty has its own neural profile, has its own clinical presentation and impairment, you may not be able to find your results in line with your hypothesis. So when you do research in autism, do screen for psychopathologies, do try to control for them if you can. If you don't, they can then they can become a confounder in your results. These psychopathologies are not only present in the youth, which I mentioned, they're equally damning in adult population. So no matter you do research in youth or adults, you need to be mindful of controlling for these psychopathological situations, or at least screen for them and have a profile for them available for your research when you have the results to see if these factors were moderating the outcome. One more aspect of autism is that it is so disabling, and these are survival curves. I just quickly want to tell you that these are the controls showing all the other all the disorders, major psychiatric disorders, how they, at what age they tend to appear. You notice here with autism, between the ages of 10 and 14, majority of the psychiatric conditions emerge earlier than what you expect in the typical population, or what you even expect in this psychiatric controlled population with ADHD. So not only that they suffer from psychiatric condition, they also have the onset of these conditions way earlier than what you see in the typical population. Okay. So I've sold you this idea that I am needed with the autism population as a psychiatrist. I have a role to play, right? Now, we now dive into the neural findings. We look at, because part of what we do is in our lab is that we clinically characterize this population, try to understand their unique presentation and their diverse and heterogeneous presentation. And then also at the same time, we try to look at the neural correlates of autism and associated psychopathology. Here are one of the first studies we did, and let me just set the stage for you. Resting state functional connectivity, I'm sure many of you know, but I'm just going to go through this little bit of historical background to it. Resting state. Now, I can, if I ask this question, and because this is not a dialogue right now, is that which organ in the body consumes maximum energy? I'll give you the answer, it's the brain. When does the brain consume maximum energy? When you're doing a task, or you are just sitting idle? Actually, when you're sitting idle, the whole brain is activated and uses maximum glucose at that time. So never let your spouse believe that you're lazy. When you're lazing, your brain is probably consuming more glucose than when you're doing some act, right? Resting state connectivity became a very powerful tool to understand brain connections for one good reason. In our brain, if we look at the structural connectivity, it is pretty much like the Google map, in which you have these major highways running across the country, left to right, north to south. And then you have all these tiny little roads and other things. And if you go back in the Google map, and when you only see the highways and you don't see small roads or smaller highways, That is probably how much we know about the structural connectivity in humans. In humans, we don't directly know much about this, the brain connectivity, because it is very difficult to do that in a live person. They do that in macaque monkeys. They cryo freeze them and then they look at the connectivities. So another tool which has become important to read, to understand the connectivity in brain is a resting state. And what we do is we put people in MRI, tell them to just close their eyes. And while they are doing nothing, the brain is still very active and it's going in oscillation. And there are certain networks which are very prominent when you're not making or doing any activity, which are called the task negative network. And the one which is most prominent is the default mode network. That means it's like pretty much like an idle engine. It's going, and these are regions in the brain which are sort of going in unison, up and down. What are those regions? These are the medial prefrontal cortex, the posterior cingulate cortex, the lateral parietal regions, which from predominantly angular gyri. These regions are oscillating powerfully at that time. Not only they are oscillating powerfully at that time, they also do one tricky thing. They suppress the task positive regions. They toggle at the TPJ and suppress the task positive region. And so when the default mode is active, the task positive region is deactivated. When the task positive region gets activated when you're doing something externally, the default mode gets suppressed. Now, default mode is also active when you're engaged in internal emotions or external interpersonal emotions. And guess what? That is where it's important for autism. So we did this study and we found a few interesting things. We found that the three nodes of the default mode, the angular gyri and the medial prefrontal cortex, the blue here is the healthy control, the strength of the coupling of the healthy controls, and orange is the autism strength. You notice that the coupling, that the inter-network coupling of these nodes was poor in autism versus the healthy control. Basically saying that the default mode network's muscle activity was weaker in autism than you see in folks without autism, which tells you maybe it's related to their lack of introspective ability, their lack of psychological mindedness, their lack of emotional processing internally or externally, that may be reflected by this weakness in the default mode network. What other interesting thing also happens here, that the networks which are supposed to be anti-correlated, and as I said that when the default mode network rises, there is the task positive network is suppressed, right? And that what we also call is the anti-correlation. That means one, like a seesaw, goes up, other goes down, one goes, if the task positive goes up, the default goes down. That seesaw, that strength of that suppression of each other was also weak. And what happened is that these two regions, which are right fusiform gyri and the supramarginal gyrus, which is part of the temporoparietal junction, which does the toggling between these networks, they, interestingly, rather than being anti-correlated, what you see in the typicals in blue here, they become positively correlating with the default mode. They were also activated while the default was activated. And that probably messes up the default mode function. Because if you have task positive regions activated at the same time, and that could be one reason in autism, they cannot tolerate idle time. They cannot tolerate introspectivity because they cannot focus internally because the default mode is not working properly. It's weak. And also these task positive regions constantly bombard the default mode and they are always distracted outside. Okay, I gave you that storyline, but here is the interesting piece. Now, in our older research, we would do this. Well, take the means, and this is what the problem is. But that we know that autism is a heterogeneous disorder. So are the default mode difficulties. What kind of weaknesses, which node has it, how much it has it, are very diverse in this population and should be, because clinically it's a very diverse population. What did we find? We find that, let's take the example of the resting state strength on the left lateral parietal junction, the angular gyri. What we see in the controls, as a mean, it's high, right? In ASD, it's weak, low. But if you notice the distribution, how wide the distribution of each person's strength of the node is. You notice here that some people definitely have high, way higher than the lower, even in the control population. And in the autism population, you notice that some of them are coming close to the normal with the controls. So it cannot be said that every individual has the same profile of a default mode network connectivity abnormality as the whole group had. So what we did is this. We did a machine learning thing, and we looked into the unsupervised cluster analysis. What basically it means is this is what we did. Like we take all the patients, all of them, including the autism patients, which are in a triangle, and the healthy controls, which are in circles. We put them together. We did this machine learning where we just shook them to see what clusters are found which share the same default mode connectivity difficulties. Two things stood out. There were 5 clusters we found. 2 of them were just purely in the general population, healthy controls. This one cluster only had healthy controls. This other cluster only had healthy controls, no autism. Very much reflecting that even in the general population, the default mode network is not the same. It cannot be. If we are, as a community, we are diverse, our default mode network will have some variability which reflects our uniqueness, right? Then there were 2 clusters which were purely autism. These triangles, the yellow one and the blue one, which falls in this range here in the general population. They were abnormal, but their abnormalities were not uniform. They were within abnormal, they had 2 different abnormal groups. And then guess what? There was in this middle, the green one, which had a combination of both the healthy control in circle and the triangles, that is the autism. So doesn't it show the neural profile of diversity of the default mode network, from normal showing different kind of normals to abnormal showing different kind of abnormal, and in the middle is a mix. Pretty much what I showed you in the beginning about the general population, how the autistic traits, they spread out in the general population. So does the default mode network connectivity. And even in the typicals, it could have different forms of default mode functioning. Okay. One more thing we did is that, remember we talked about the default mode network. That means basically the regions in the default mode network, they connect with each other. And that is the task negative network, the default mode. Then the other, we talked about the task positive network, which is anti-correlated with this. We looked at the most strongest connectivity, the minimum spanning tree analysis, they call it, between these regions which were abnormal in healthy control, which are normal in autism, to see what kind of connectivity as a network they had in themselves and between the task positive and task negative. The task negative, the default is in blues, and in yellows of different shades are the task positive network. One would ideally expect that the minimum spanning tree, the nodes which are part of the network should connect with each other first. And this only shows the most prominent connectivity. They could be connected to others, but the most prominent connectivity should be within themselves, within the network, right? And then the task positive networks should have their own connectivity with each other, with their own members. And then they may be connected to the task negative network through other ways. What we found that in the healthy control, this kind of pattern of task negative regions were connecting with each other first, then the task positive were connecting with themselves, and then there was connectivity between them. It was out of 16 subjects we had, in 15, that pattern was true, except for one subject where one of these blue here went into the task positive network. That means it was abnormal in 1 out of 16 of the healthy control. In autism, on the other hand, my golly, look at this. The yellow, the task positive network region, is now part of the default mode network. Remember, I told you that some region joined the default mode, and that pattern did show up in roughly 2/3 of the autism population. We are going to repeat this, and because repetition sometimes is very essential in a larger population, see if this pans out true. If it does, this could become a biomarker for early recognition of autism even before they have social impairments in their lives. Let's move on. Now, when we were doing this resting state analysis and studies, we only in our MATLAB, the software we were using, we had only mapped out the cerebrum and some of the subcortical region. We are oftentimes thinking the cerebellum is not involved in autism, use cerebellar region as a control. Now we know that cerebellum is essential for motor coordination. Cerebellum is also essential for social coordination. And the social coordination difficulties people may have underpinnings in the abnormal cerebellar functioning. The other important piece is the cerebellum has a lot of gray matter like the cerebral cortex. And for me, interestingly, because I work in the glutamate neurotransmitter systems, after the cerebrum, the most dense glutamatic activity in the brain happens after the cerebrum, that means cerebral cortex, the most intense glutamate activity happens in the cerebellum. So we included cerebellum in our analysis to see whether cerebellum has some abnormalities, and we started agnostic. What we did, we took a resting state function connectivity of the whole brain of the controls, then of the autism, and first we did what we call as the whole brain connectome-wide multivariate pattern analysis, just to see what differences in the resting state come out by region between autism and healthy controls. And we found that there were two regions, and I'm not going to go into details here, in the cerebellum, in the social emotional region of the cerebellum, turn out to be underconnected, poorer connectivity when you compare that with the healthy controls. Now, what we did, then we took these two regions, which turned out to be in the whole brain as abnormal in the autism group, to see where were these two regions, if we made them the seed, where were they connecting? And we found that they were connecting with a lot of cerebral regions poorly, and most of them were social brain regions. Not going into details because this will consume another lecture if I want to. We also did this. We looked at the gray matter differences between autism and healthy controls, and then they used those regions where the gray matter differences were to see what was their resting state function connectivity in autism versus healthy controls. What we found here that the two regions which came out. Now, remember these two studies, there was no a priori literature-based region of interest. We actually dug out the region of interest based on what differences showed up, rather than based on hypothesis or coming up with our own regions of interest based on literature. So now here we found that in the right cerebellum region, there was hypo gray matter, reduced gray matter volume in cerebellum. And the other region was increased gray matter volume in the right temporal posterior part of the temporal lobe, which is very close to the TPJ, which is very relevant with autism. So we found two abnormalities in autism: increased gray matter on the right temporal region and decreased gray matter in the cerebellum. When we looked at the resting state connectivity, there was no abnormality we found with the right posterior middle temporal lobe increased gray matter region with the rest of the brain. The abnormalities we found only with the right cerebellar region, connecting to the somatosensory processing areas, primary visual processing areas, which we know that they have sensory dysregulation, so this may play a role there. Okay, we move on. In the structural connectivity analysis we did in small samples, we have found that and this we have done in multiple samples, but we haven't even have not published it yet, that there was underconnectivity of the uncinate fasciculus. In this particular one I'm showing the left, we have another study showing it's the right. It seems that uncinate fasciculus, which connects the medial temporal lobe, which is a emotional social processing region, to the orbitofrontal cortex, which is a very powerful region for executive functioning and assessing the social situation and responding to it, that connectivity is poor in autism. And we have seen this in multiple subsets of data we have. Now, I want to talk to you about a little bit. ADHD is the most common disorder in high functioning autism, and it is the most debilitating. Look, autism, they have few strengths. Intellectual strength is often what they have. And ADHD is far more impairing in intellectually functioning population because it really, really impairs intellectual function. So there has been a historical perspective about autism that if you have autism, you cannot have ADHD. And just to give you one example, they say why you cannot have ADHD is because if you can hyper focus on your preferred activities, then you don't have ADHD. How can you have ADHD if you can really focus? Actually, even in the typical population, not all, but most of them can hyper focus on playing video games. ADHD is very contextual. It's only tested when you're trying to do an activity which is not of your interest, or it is essential, but you're not good at it. So we said, okay, if you think that ADHD is not part and parcel of autism, let's do two things. One, let's look at the clinical presentation of ADHD and autism and see how similar or dissimilar it is from the DSM or the typical presentation of ADHD. We put the symptoms together. In blue are the typical symptoms of ADHD in both domains, in attention and hyperactive. There are two domains of ADHD. And then we looked at the ADHD symptoms in autism in orange. And we found that fairly all the symptoms are present at the same rate, whether you have ASD or you don't have ASD. The clinical presentation is very similar. Then we went on to look at the neural profile. We said, okay, we have this clinical presentation, which is similar, typical. The argument now we hear is that their treatment response is poor, so maybe the neural profile is different. We started this study 5 years ago, and we said, okay, we will look at the neural profile, different dimensions of it. I'm only reporting on the DTI right now to see if the neural profile, what we see in ADHD, typical ADHD, if that is replicated in individuals with autism who have ADHD. And we found that the cingulum corpus callosal tract underconnectivity, which we found in the ADHD, was replicated in autism folks who had ADHD. Okay. Now I'm going to talk to you about this, one of my favorite areas of where most of the research is going on at the moment, is about the excitatory inhibitory imbalance in ASD. Now we know that brain has two major neurotransmitters, the glutamate and the GABA. The glutamate is excitatory, the GABA is inhibitory. There's a delicate balance between the two. And a lot of research has cited that there is an imbalance in this neurotransmitter system, which have attributed to ASD. We do proton spectroscopy at 40. One of the interesting piece, so I think most of the people know what this is, but I'll just repeat what we do, that we take a certain area of the brain, we extract data from there, we do post-processing, and depending on what kind of machine you have, how powerful, and what kind of post-processing you have, decides whether you can separate the glutamate peak, which is buried under the glutamine, and the GABA, the two other one inactive and one active neurotransmitter associated with the glutamate system. You can separate these peaks out. So we use 40 and we use JPRESS technique, post-processing, to separate glutamate from glutamine and GABA, because we wanted it to see the glutamate activity. What we did, we published this on a high functioning population. They were adolescents, only males with autism. And we found that in the two regions of the brain which we targeted initially, one was the anterior cingulate cortex, in particular the pregeneal cortex, which is the hub where the limbic emotions and all the sensory input comes, and the prefrontal cortex input is coming in this region. Pregeneal ACC, the most dominant neurotransmitter there is glutamate, and this activity between the prefrontal and the limbic system decides your response, and it has a very affective and social response as part of its operations. We looked at this. And then the medial temporal lobe, which has the anterior hippocampus and the amygdala, which are social emotional processing regions. We looked at their glutamate activity. Our findings were interesting. We found that the glutamate activity in the autism folks was higher than what you see in the typicals, in the ACC only. They were not high. They were similar to typicals in the medial temporal lobe. What this tells you that if the glutamate activity is high, it's not globally high in the cerebrum. It is regionally, you may have abnormalities. And in autism, we found that the regional abnormality was limited to pregeneal ACC. And it at the least told us that this abnormality is not global in the brain. Once you know, as a clinician psychiatrist, that there is a glutamate dysregulation, the natural step then is to see what kind of treatment options we can use to bring this glutamate activity down. Anti-glutamate agent, memantine, is a FDA-approved medication for dementia. It is very well tolerated. It is a glutamate modulator. And we studied this medication in autism folks to see if it improves their social functioning. We had earlier done a study to show that it improves ADHD, but we did this knowing that they have glutamate abnormality. And this was the publication. So what we found is that the folks who took this medication for 20 weeks, first of all, they tolerated this well, up to 20 milligrams a day, and the social functioning improved. And the improvement in the social functioning were, what we observed were in that they were more curious about people, they were more expressive about emotions, they were more sort of able to be flexible enough to understand other person's point of view, less argumentative, and they showed flexibility in their day-to-day working. It was well tolerated. I don't have to go into the details of it. If someone needs to, can reach out to me. I can give them more literature on this. One more interesting thing we found, when we stacked that adult population with autism from the youngest subject, 18-year-old, to the oldest subject, 47-year-old, and we looked at the response, a very interesting trend emerged. The response was lopsided more with the younger population, not with the older. The older population did not tolerate this medication as well and did not respond as well as did the younger population between 18 and 29. This led us to look at the glutamate activity in the pregenial ACC in individuals with autism, cross-sectional studies. And when we stacked those studies done in the preschoolers, in the children, in the adolescent, in the adults, we saw an interesting pattern here. If 0 is the normal, what the glutamate should be in the typicals, in autism, we found that the preschooler study showed the glutamate activity in the pregenial ACC was as in the typicals. It started increasing in the children, peaked in adolescents, and then it became less than typicals in adults. There is this hypothesis with glutamate that if it is overactive, it burns out its own cell, and it's that excitotoxicity then leads to irreparable loss of glutaminergic function in individuals with autism. This also tells us that we need to catch this early, regulate this early, like pretty much like juvenile diabetes. If you don't catch it early, it's going to do damage. And you need to catch it early enough before the damage is done. Okay, so these studies and this preliminary study led to this grant, where we did a neuroimaging informed pharmacotherapy. Basically what we did is this. We took those teenagers, the very ones who are suffering the most with autism. We treated them with 12 weeks, the very way we did with the adults, with the memantine. But here we did an interesting thing. We did a spectroscopic scan of the pregenial ACC before giving the memantine, and then repeated that scan after 12 weeks after giving the memantine. We also took healthy controls where to test the stability of memantine over 12 weeks, we repeated their scans between 12 weeks, sorry. What did we find? Again, as our preliminary data showed, the glutamate activity was significantly high in autism group in the pregenial ACC than in healthy controls. And that activity moderately, positively correlated with the severity of autism. So there seems to be a connection between the glutamate activity and the autism impairment, what we see clinically. We then did this interesting, and I do this all the time. I just put all the folks, healthy controls in blue, autism in orange, and just tagged them from the lowest strength of the glutamate level activity to the highest. You do see a pattern here, don't you? The same pattern of heterogeneity and overlap. Look what happened here. At the lowest end were purely healthy controls, no autism. At the highest end were purely autism, no healthy controls or typicals without autism, right? In the middle was this darn mixture. What we then did, we did a z-scoring to find out thresholds of abnormal functioning. And we did a 1 standard deviation above the mean score on the typicals to say that above that, we will call high glutamate activity. If they are within the range of 1 standard deviation here in green, we'll call normal glutamate activity. If they're below the 1 standard deviation, we'll call the low glutamate activity. Guess what you notice here? That 60% of the folks had high glutamate activity, 40% roughly had normal glutamate activity, and none, I repeat, none had low glutamate activity. So we found a subtype of autism, which has abnormally high glutamate activity. Now, in the study, again, 20 milligrams, they tolerated that well. Side effects were not none of the side effects were more significant than the placebo. So it was well received by the patient population. And we found that memantine was 5 times with a greater response in the autism population. Sorry, with memantine, we had 5 times greater response than with placebo. So memantine did show a significant improvement in autism than the placebo did, which was 21%, right? When we divided the population between 2 groups, high glutamate activity, remember that? The 60% versus normal glutamate activity, 40%. Let me say this. If you have diabetes, if you have high sugars, I give you insulin, probably you'll be happy. If you don't have high sugar and I give you insulin, what's going to happen? You're not going to respond well, right? Look at this. All the responders in the memantine group were in the high glutamate activity sample. None of the responders were in the normal glutamate activity sample. Not even a single responder on glutamate was in this normal group. If you notice the placebo response, it's pretty stable across high or normal, but it's the memantine response, which is exclusively in the high glutamate. So the high glutamate activity could be a predictor of response to memantine. So we can select a population prior hand to see if they're high glutamate, there's a fair chance they may respond to memantine. Now, we looked at the pre and the post. This may get a little boring, but just bear with me. Pre and post levels of glutamate in the autism population, but we repeated them in a healthy control to see what is the level of stability of glutamate activity in healthy controls over 12-week time. The glutamate activity in healthy controls did not significantly change in 12 weeks. So the changes, what you're going to notice now, what I'm going to talk about before and after treatment memantine are not happening due to natural variation of glutamate activity. They're happening probably because of the memantine treatment or placebo treatment. Here's a striking thing. What we did, now let's say the red is the responders, blue are the non-responders, and green are the glutamate levels in healthy controls. Interestingly, what we found when we just took the sample based on whoever responded versus whoever didn't respond, no matter whether they were on memantine or placebo, the glutamate level significantly came down in the responders than the non-responders. In fact, I will show you that anybody who responded, even on placebo, their glutamate levels came down. Anybody who did not respond, even on memantine, the glutamate levels did not come down significantly in pregenial ACC. This is how strong this coupling is between the glutamate activity in pregenial ACC and the clinical presentation. We looked at the memantine group. It was the responders who came down to normal who took memantine. The ones who did not respond, the glutamate level in 12 weeks did not shift at all. If you look at the placebo group, you'll find that even the placebo, the responders came down to normal, as if placebo is not a fake response. Placebo has a lot of psychological power to it. And also learning about autism by the families and how they react with the kid. Anybody's who showed improvement on placebo, their glutamate level also came down to normal. The ones who did not, the glutamate levels remained higher than the normal. This is my last slide, and here's what I want to show you. I want to show you that these, in the circles are memantine treated, in the square are placebo treated group. This is the high glutamate sample of 20. This is the normal glutamate sample. This is the starting point before taking memantine. And this is the end point where the glutamate level came after taking memantine. Notice one thing. All the responders, which are in green here, their glutamate levels came down to the normal range after treatment. In the red, who did not respond, non-responder, the glutamate levels did come down a little in some, but they still remained high. They did not come to normal, right? Interestingly, in the normal group, you'll see that the glutamate levels were moving up and down as if they're trying to seek the normal, but they were in the normal range, and most of them were non-responders. So there is a powerful story I'm trying to tell you that the glutamate level in PGACC, pregenial ACC, may be tightly linked to the clinical severity of autism, which we see in our population. So in the end, there's a greater recognition of autism in intellectually capable populations. The functional neural connectivity profile in autism shows a heterogeneous pattern, as does the clinical expression of it. The structural connectivity profile associated with ADD is expressed very much like what you see typically. There is a selectively abnormally high glutamate activity in the pregeneal ACC of individuals with autism. And this high glutamate activity correlates with the severity of autism. And also this could be heralding a subtype of autism in high functioning population, which has abnormal glutamate activity. And that could be a biomarker for disease to recognize earlier enough before the impairment show up, or a predictor of response to glutamate modulating agents. Thank you.
Wonderful. Thank you, Dr. Gagan. Looks like you just stopped sharing the screen. Thank you very much for that incredibly interesting and informative presentation. I'll be moderating Q&A for 15 or 20 minutes here. Is that how much time we have? So if you have questions, what I'd like you to do is turn on your camera. That way I'll know that you have a question. And then if several people have them on at the same time, they can raise their hands and I'll call on folks. Looks like Dr. Semwal has one to start us off.